vaccine for the adult high-risk groups in Jordan, especially with the current pandemic. I do hope that it will be within the national immunization program, as we discussed. This is highly needed for prevention of flu infections that has a major health and economic burden of the country. So we do encourage that this will stay also for the coming years. I will ask this question at the end of the presentation. What do we miss in Jordan in terms of flu vaccine selection and utilization? Influenza virus. Dr. Hamd gave us a brief about the influenza virus and about the medical treatments. I'll just go through the vaccine and some related aspects to these vaccines. We know we have type A and B and C, and type A, B, C, we have type A, H1N1 like H2 and 2, and then we have the Yamagata and the Victoria for type B and other ones. We'll discuss them in a minute, and we have also type C. Worried about the history of the first reported pandemic during the First World War with the millions of people who died, especially in Spain. We have type A that affect humans and animals, and we have also the type B affect predominantly humans, and C the same, rarely reported in humans, but mainly in other mammals or birds. And this is the pandemic occurred during the First World War, and you see it was mainly in London, Paris, New York, and other countries. It's very important to understand two concepts, actually. We are now facing the COVID-19 pandemic. Actually, when I was in the UK in 2009, we were preparing for the pandemic from flu virus, actually. And unfortunately, actually, governments changed, but I think the Labour government would have done much better than the Conservative Party, because we're actually prepared even how to do the test, how to handle the medication to everyone at home. They should not be going to the hospital. The main lesson I learned actually during the preparation for the pandemic for flu in 2009 in the UK was, don't ask suspected cases to come to the healthcare facilities. They should, if someone suspected during the pandemic from COVID-19, someone with the flu, during flu pandemic, hopefully it will never happen. You should, those with symptoms suggestive of this one, we should send someone to their home and take the sample rather than people coming to the hospitals and to infect the healthcare staff and to infect other patients. So I just want to refresh our mind about these things, because this is critical in the pandemic control. So why we have some infections, they have pandemic or epidemics, there is something related to the influenza virus. Actually, this is why we keep updating the vaccines every year, because there is something we call antigenic shift and antigenic drift. The antigenic drift is minor changes that occur in the hemagglutinin or neuraminidase service, and this will change the available serotype, make changes in the service. These are minor changes. The major concern, and it will not affect actually most responses to the influenza virus. It will not make it as serious as the antigenic shift, where we have major changes resulting in new subtype or two previous types, they merge together. And this is the main cause of the pandemic, the antigenic shift. So the H1N1 2009 was a classical example of where the avian and swine flu, they combined with the antigenic shift for the flu in the humans, and they led to the H1N1. And we have to be careful about the antigenic shift, because this is the major cause of the burden. And this is the danger of the flu virus. Less serious is the antigenic drift that occur in the, as we said, in the service antigens, and this is like the 2003 and 4, the H3N2 flu season. So you can see this over many years, the flu virus used to change and to change its subtypes and change its service antigens, and this is why it's very difficult virus to control. Because of that, we had experienced several pandemics, and like 50 to 100 million died in 1918. Then we have in 1959, then 1968 and 2009, that, we had the H1N1. It's very essential before we discuss the vaccines that we know what is happening actually. What are the strains that is causing the infections? If you look at this one, we look at the global, and later on we'll look at different hemispheres. So you can see that 39% of the infections are from A, H3N2, then we have followed by influenza B, then H1N1, and then influenza A in a subtype. So, the infection will spread through different ways: direct contact, environment, air, and this will lead to the symptoms, and the contagious period is up to 9 days. And this is why it's very important to remember the two lectures from my colleagues about the infection control. And this is one of the key things that we have to understand, both at the community and at the hospital level, how we control these infection transmission. Symptoms, complication, influenza, it's a wide range of systematic impacts from the respiratory tract, neurological, nervous, musculoskeletal, and GIT symptoms. So we have a wide range of manifestations. The good thing that not all people infected will present with symptoms. Some large number of cases are symptomatic, and then we have mild to severe. And as we'll discuss throughout the presentation, we have the high-risk groups: pregnant women, elderly above the age 65, immunocompromised patients. These ones that we need to keep an eye on them, because once the infection is there, it will lead to more complications. So some patients will have bacterial infections, especially very young, high-risk groups, elderlies, and we have usually it's symptomatic treatment unless the patient is hospitalized or they have complications. So the recommendation of Dr. Hamid will keep it only for the hospitalized patient, the high-risk influenza complications. Symptoms, influenza A or B, usually they are the same with minor differences. So we have to keep these serious complications, especially during pregnancy, elderly, and below the 2 years of age, and also those with the chronic cardiac, heart, kidney, or liver, or blood disorders. These are just some main differences, but you can see the mortality is actually higher from influenza B compared to influenza A. And this is why we need to keep an eye on the strains, subtypes or strains from the from influenza B to be covered during the vaccine. If you look at the symptoms, I like the conclusion from Dr. Hamid. He said that sometimes patient might have both COVID-19 and flu. This is having flu and influenza virus positive, doesn't rule out COVID-19, but you can see there is many symptoms in common between the COVID-19 and between influenza. And this is why we have to be prepared for the next flu season. The annual attack rate of the influenza is around 5 to 10% of all adults globally. You can see it's a big number actually, and 20 to 30% in kids. And this is why we need to be alert always for the changes in the flu. And actually I was expecting the next pandemic to be from flu, not from the COVID-19. That's what happened. But you can see during previous years, especially the last 2-3 years, we have around 290,000 to 650,000 estimated deaths worldwide from the flu infections. The good thing now, we have a global surveillance for flu. And this is a key actually to develop vaccines and to ensure that we have data to when we select the vaccines for our countries. If you look at the economic burden of the flu vaccine, you can see it's a major impact on the economy. Like, for example, in the States, it's around 5.8 billion annually from flu infections. Although in the States, actually, they have wide recommendation for all age groups to have the flu vaccine. But you can see later on today, I'll show you differences in recommendation for the flu vaccine between countries. And we can tell from this figure why in the States they recommend a mass vaccination for the flu. But when compared with strep pneumonia, with herpes zoster, HPV, and hepatitis B, we should have it at least for the high-risk groups, elderly, pregnant women in Jordan. Another important thing, because secondary bacterial infections and other things, it's very important to assess the impact of influenza vaccination on antimicrobial resistance. So this is another added value for the flu vaccine. You can see from this figure, actually, although the attack rate is high among pediatric age group, but the mortality is high among elderlies. And I think we'll discuss this on Thursday during the presentation on the value of vaccines. Actually, now we are vaccinating our kids to protect the elderlies, not just the elderlies themselves, because these kids, they have high attack rate, they spread the infection to the elderly, to pregnant women, to high-risk group patients. So we need to keep an eye on the vaccination of flu for those below the age of 5. The different studies actually have been done. We are working now on a study. We hope to start sometime soon on the cost effectiveness of influenza vaccination for elderly and different high-risk groups, to show data from Jordan about the groups that should be prioritized in the introduction of the flu vaccine. But previous studies show that it's cost effective for those above the age 65, patient with COPD, bronchial asthma, cancer, diabetes, chronic cardiac disease, hemodialysis, and in HIV patients. And systematic review was done to compare the value of the vaccine introduction. You can see here that the vaccine can reduce the number of cases for one vaccine. If you vaccinate 71 subjects with the flu vaccine, you're going to prevent one case. While, for example, rotavirus, you need to vaccinate 200 kids to prevent one case. You can see that it's very important to introduce the flu vaccine when compared with other vaccines within the systems, either in Jordan or globally. I emailed Dr. Kamil yesterday that I can't attend with you guys, but please put the COPD at the top of your list for the prevention of the flu, because we need to ensure that all our patients with COPD should have the flu vaccine. The impact is really very high. When a COPD patient have the flu, the mortality rate is around 300 higher than the healthy adults. Then we have the pregnant women, children age 6 to 5 years, we have elderly, and we have other diabetes, asthma, chronic heart disease, especially heart failure, and we have other factors. Actually, when I was in the UK, I was asked by my seniors to look at recommendations for different clinical illnesses like cancer, diabetes, thyroid, and some vaccines, to look at the heterogeneity in the recommendations, actually. Each country, we have different recommendations played by the system. So I encourage also our region to look for data from our region, and also to have recommendation based on our local data, original data. The impact of flu vaccine is very important, especially during pregnancy and also for other groups. Diabetes is highly important. The risk of mortality 3 times than higher adults, but we have also other priorities that should be, I believe that we should put it within the top 10, but not the first 5. Healthcare workers. I believe that it should be compulsory, actually. In Jordan, it should not be voluntary by the healthcare workers unless it's contraindicated. We work in different hospitals in the UK and the US. You cannot start your job without having certain vaccines. You should adhere to the different vaccines like the flu vaccine. We are exposed, we spread the infection between different patients. We are handling immunocompromised patients, patient at risk, patient with different age groups. So I believe that healthcare workers should have the vaccine compulsory, not as a voluntary aspect. Interesting results actually showing that patients with COPD, when they receive the vaccine, not just we prevented the pneumonia and other infections from influenza virus, but we managed the vaccine prevented coronary syndrome like myocardial infarction or acute angina. So the impact is not just because for the, I believe that there is some other confounding factors that contributed also to the prevention, but we can see because this acute severe infection can affect also the metabolic, the coronary syndrome. So the impact of COPD is not just prevention of infections, complication, it's also added value that it will prevent acute coronary syndrome. This is what we mentioned earlier, that if you have a school-based program for a flu vaccine, you are going to prevent it also for elderlies. The vaccine history started in 1920, the first vaccine introduced in 1970, then we have annual changes. In 2013, I think the quadrivalent was introduced, and it's very important to understand differences between the key difference between trivalent and quadrivalent is that beta Yamagata and or beta Victoria are both present quadrivalent, or one of them will be present trivalent vaccine. There is around 30 or 40 vaccines for flu in the market, but we have to look at the serology in our country and the data from the epidemiological surveillance to decide which one should be used in our countries. But currently, quadrivalent are needed. I don't encourage country to invest in trivalent vaccine, especially based on the data, global original data for the last 5 years. WHO in February 2019 recommended these influenza season to contain the vaccine should contain the following flu virus types, and also in some cases if they include the certain seasons, especially in the northern hemisphere, they can use the trivalent, but I don't encourage this personally. So we have an annual process of recommendation. We keep the selection of the vaccine strains in January, then in February we look at the genetic manipulation, then we produce the vaccine in April, usually it's ready in September, and we encourage the flu in our region actually in the in late October or early October. So you can see that in the Northern Hemisphere, since 1989, there's 41 different flu vaccine strains. So since 2013, the WHO recommending quadrivalent vaccine, and this is what we are encouraging also to be utilized in Jordan. When I should get vaccinated, depends. Are you based in Jordan? Are you based in Australia? Are you based in Sudan or Yemen or Brazil, where in tropical countries? So the incidences vary according to the winter season in each hemisphere. The key to the vaccine's efficacy is the available strains in your country. So if you are prepared to the current epidemiological surveillance, then efficacy will be high. If you are just utilizing the vaccines available based on data from outside your region, the efficacy will not be high. So this is very important, actually. We need to assess if we are vaccinating this season, the next season, like the different high-risk groups. I believe that we should be looking at the efficacy and the incidence among these groups. I will encourage my colleagues, and I will be working with them if we are going to vaccinate. Certain groups, we need to look at the efficacy of this one, the incidence among the vaccinated groups, assess the efficacy. I'll skip these slides for the sake of time. Dr. Ghazi is asking me to speed. Efficacy and effectiveness. Efficacy is, does the influenza vaccine work? And this is based on clinical trials. Effectiveness, what's the impact on the individuals and the society? In the States, actually, the CDC recommended that they look at the last season, and they look at the surveillance, and they look at the common strains, and this is why they recommended the quadrivalent vaccine based on the local data. And this is done on every year. They sit sometime in March and decide on what should be included in the next season vaccine. And this is what should be doing. Actually, vaccine coverage is a global issue, it's not just in our region. We need to try to increase uptake. It's very important that physicians play a role, actually. The physician advised to pay, if the patient attitude is positive to the vaccine, the uptake rate is 87%. If the physician attitude to the vaccine, patient attitude is negative, while the physician advised them, I will finish in a minute, in half a minute. If the patient attitude is negative, while they receive a physician recommendation, 70% they are likely to receive the vaccine. While the patient attitude is positive, but the physician doesn't recommend the vaccine, look at the uptake, it's 8%. So you can see that it's very essential that physicians play a role in the in promotion for the flu vaccine. I'll skip these slides, just go to the final slide. What do you miss in Jordan in terms of the flu vaccine selection and utilization? I believe that we need to look at the epidemiology and antigenic characteristics, recent influenza isolate and surgical responses 2019-20, an assessment of the uptake rate, barriers and the uptake, assessment of cost effectiveness among different groups. Thank you very much.